Welcome. My name is Tyler CYMET. I'm Chief of Clinical Education at the American Association of Colleges of Osteopathic Medicine. And thank you for coming today to learn more about COVID-19 and what's going on. COVID-19 is a crisis. It's changing how we do things. It's also a new disease we didn't know before. So we're going to use osteopathic thinking and go through the basic sciences, go through the clinical presentation, talk about how we test for this, and some of the ethical considerations that need to be taken into consideration as we traverse this issue. We have faculty from the osteopathic medical schools, starting with Dr. Valerie Cadet from PCOM-Georgia, Dr. Paige Gutheil from OUHCOM, and we have Bindu Mayi from Nova Southeastern and Daniel Hurst from Rowan University, all helping us go through some of the information we need to understand the virus. So thank you for joining us, and we're going to start with Dr. Valerie Cadet. Good morning. Welcome.
Good
I'm very
morning.
happy to have Valerie Cadet with me from PCOM-Georgia. Dr. Cadet is a PhD in infectious diseases and has been educating us about coronavirus and what's going on. So welcome, Dr. Cadet.
Thank you.
Dr. Cadet, what is going on with coronavirus?
So what's going on is that we have this virus that is a virus in a family of viruses that we've known before, but it's brand new. This particular one has never been seen before in humans. And so now that it's emerged in humans for the first time, it's causing widespread illness. Well, at least it's causing widespread, disruption because nobody has seen it before.
When you say it's brand new and no one's seen it before, we know coronaviruses, we know paramyxoviruses, we know, isn't this the virus that causes the common cold?
Well, yeah, we actually have 5 human coronaviruses that we know very well about. If you picked up a bottle of, any sort of cleaning solution, a lot of them will say effective against human coronaviruses. And for the most part, they do cause common colds seasonally, just about every year. The thing about it is that this is a brand new virus in that same virus family, that what we're seeing is because we have no pre-existing immunity in our population, it's sweeping through pretty broadly, and it is causing, more mild symptoms similar to a cold, or, maybe a more severe cold in a lot of people, but it's causing more severe disease in others. And frankly, this isn't the first time. So coronaviruses are actually typically going to be found in animals. So there's lots of coronaviruses in cows, in bats, in cats, certain types of cats, and other animals. And what ends up happening is that these viruses have eventually made the jump, let's say, from the animal species to humans. And that's where we've gotten the bulk of the 5 that we already know. But prior to this particular outbreak that we're experiencing now, we've had 2 major situations back in 2003 with SARS coronavirus, and in 2014 with MERS coronavirus, where again we had a brand new coronavirus, not one of the ones that were already circulating causing common colds, and they cause more severe disease.
So would exposure to coronavirus in the past make you more likely to have some cross-reactivity and protection from this coronavirus?
It's really hard to say. My gut says probably not, just because studies have shown that population studies have shown that when they're looking for exposure to coronaviruses, and we're talking about one of the 5 that cause common colds, for the most part, most people have been infected with one or several of them over time. And so if we kind of took those studies that have been done in various locations and we expanded that to say that most of us have already been exposed to coronaviruses, well, then that probably wouldn't hold true, because a lot of us are still susceptible to this particular coronavirus, as we can see looking around the world, and as we're seeing it spread throughout the United States.
Beautiful. And you said it lives in animals like cows, bats, and cats?
Just to name, a few, but yes, cows, camels. In fact, the MERS, Middle Eastern Respiratory Syndrome, actually, was an emergence from camel. Now we think that, so there's a couple of different, clades of these viruses. So the ones that we've seen with SARS, with MERS, with COVID-19, as well as, a couple of the 5 that are circulating causing common colds, we believe that they emerged originally from bats. So the idea would be the bat is infected, and then the bat, somehow there's a transmission to some animal, for the most part, most likely, and then from that animal to humans. And so in that case of MERS, for instance, we saw that from camels to humans. As of right now, we don't know if that is in fact the case. It looks like it's likely the case, but we still have to identify an animal species and, find the bat host.
If it has an animal reservoir, will it be here all the time or will it still be seasonal?
Well, again, that's a question, that's a great question, but we don't know the answer to that. What we've seen with SARS and this particular virus, which is actually SARS coronavirus 2, that's how it's been named. And that SARS coronavirus 2 is what's causing COVID-19, which is actually the disease. SARS-CoV-2 was so named because it has the closest genetic similarity to SARS. What we saw with SARS is that it sort of, it caused disease and then it went away. So it hasn't been resurging as a seasonal occurrence. And we actually saw the same thing with MERS. So, and we believe that both of those were from a bat to an animal, then on to humans. So if we're following suit, hopefully it does not necessarily stay and, become a seasonal sort of epidemic, but we really don't know. And we don't know if there's an animal host.
So I'm trying to figure out the life cycle that virologists like to put together for viruses. Do we understand it yet, or how similar is it? Do you want to talk about life cycle?
Well, so we know about, in terms of the infection cycle, somewhat, we're gathering more information. What we've seen is that the virus is, of course, it's a respiratory pathogen. So when one is infected, the virus is going to, enter, it's going to begin replicating. It uses ACE2 as the receptor to get into the cells. So it actually, it embeds into the cells, penetrates, and goes through the typical life cycle of viral uncoating and then, replication of its nucleus and making proteins. And then it's going to reassemble and exit the cell. Lots of virus will exit, from one viral particle coming in. So when that ends up happening, what we're actually looking at is a situation where once one is infected, it's anywhere from 2 to 14 days before they're going to actually experience those first symptoms. And that's why we're looking at that 14-day period of self-isolation if you believe you've been exposed, because frankly, that's really wide varying. We've seen an average of 5 days from the cases in the United States, as well as cases, we'll say 5 to 6, depending on the country from the data that I've seen, number of average days, but it's still really wide. We've got 2 to 14 days for most.
So when we talk about spreading disease, we talk about 80% of people who develop COVID-19 will have a mild upper respiratory, 20% will develop pneumonia. And in the medical world, we talk about how does one become the other, and it's always aspiration, inhalation, hematogenous, and contiguous. Is this only respiratory, or is this going to be in secretions? Is it going to be in the blood?
Great question. Well, actually, what we're seeing, as far as, what I've seen, it is in the respiratory secretions. It's in droplets, it's in, nasal secretions, it's in lung secretions, but we've also found it in feces. So, we're seeing it there as well. In a small number of cases, don't have the percentage off the top of my mind, but in a small number of cases, we're looking at some people experiencing some GI disturbances as well.
If it's in the feces, why don't we see more GI? But you're saying we are.
We are seeing some. We are seeing some, and that's how we started. I believe that's kind of what led to testing to see if it's in fact present, because there are some cases of diarrhea and perhaps other low-level GI cases, but that's not in the vast majority of patients, actually.
And one of the things that's scaring me is we look at the symptom list, 97% should have a fever, 30 some odd percent should have a cough. What's in between?
It's really a wide range of people. I mean, I think that I've spoken with a lot of people, and a lot of us now have, know somebody who's either a presumptive case or somebody who's confirmed. And, the symptoms are varying from person to person. Luckily, so far, those that I have personally encountered who are, confirmed or presumptive are not at the more severe end yet. We're seeing that, the average, a major study that came out in China, I believe it was oh, I'm horrible with dates right now because it's not in front of me, but it had to be recently, right?
Uh-huh.
This major study came out where they looked at a vast majority of patients, and what they've seen, the ones that were hospitalized, of course, and what they saw was that there's an average of 9 days. So everybody's getting sicker. If you're going to get sicker, it's happening in the second week, right? And an average of 9 to 12 days after you initially had the symptom onset is when you're, at that point having to be hospitalized, and then, care being taken to the next level.
Interesting, because we talk about 900,000 hospital beds, 35 million admissions. Average admission is 8 days, and we are hearing that the admission for COVID-19 is expected to be longer. Is it bimodal, where if you intubated, it's going to be much longer, but milder for others, or is it most people who make it into the hospital are going to be there for more than 8 days?
Well, so what we're looking at, what I've seen is that, as you mentioned, about 20% of people are expected to have to need that advanced care. Of that 20%, the estimate has been about 5% of those, or I guess, those people are actually going to need the most acute advanced supportive care. And those are the people that can be in the hospital, we've seen up to 6 weeks, in fact. But the people, the bulk of the people, that 15% that actually are getting hospitalized are going to be there. We've seen an average from 3 to 4 weeks, so
Really?
more than the 8 days.
Wow.
But some of them are much shorter. It's really hard to say. And at this point, it's kind of like, we're just pulling all the data. We're always, of course, a step behind because that's what data is. And we're just looking at what we've had. Have there been cases where somebody was admitted and then, they were actually cleared within a few days? I did see a case report on that, but majority of cases are, longer. So our system is potential to be extremely taxed.
And we've heard anecdotal data about patients in China that if they were smokers, they're intubated longer. And there are some subpopulations we're identifying at greater risk. Who would you say are the subpopulations that have to worry the most?
Well, the smokers, absolutely. And we actually saw this as well with MERS. We saw that smokers fared worse, and had a longer time frame to recovery overall. And so additionally, the populations at risk are, of course, those who are immunocompromised. That could be for HIV, because they are HIV infected and have advanced disease, because they are undergoing treatment for various cancers, because of other, sorts of illnesses where they have to be on immunosuppressives like, steroids or other things. There's a variety of reasons. So those people, of course, people who have hypertension are considered at higher risk. People who have cardiovascular disease, and that covers a pretty broad umbrella, they're considered at higher risk. Type 2 diabetics as well as 1, so diabetics in general, and those who have lung diseases. Even something as, what someone would say as simple as asthma, that predisposes you to have potential for severe complications.
So a lot of the focus right now is prevention and stopping the spread, flattening the curve of how many people get sick all at once. When we talk about infectivity, how does one spread the virus besides respiratory droplets? Does it live on hard surfaces, soft surfaces?
So that's called fomite transmission, when we're talking about just touching a surface and then perhaps, inoculating yourself with it, of course, right? So I've already scratched my face during, our talk here. I'm doing much better. I hold my hands to prevent that, because those respiratory droplets that we are breathing out all the time, or sneezing or coughing out, are going to contain the virus. And so they're gonna land on surfaces, and it can be both hard or soft surfaces. And they can live on those surfaces. Now, how long they live on the surfaces can actually vary depending on the surface. So, and we're still doing a lot of testing. I've seen various tests that say that there's a distinction between, for instance, certain metals versus plastic. I don't know. I don't think we have that hard data, but we do know that the virus is. We believe the virus has a potential to linger in the air up to 2 to 3 hours. That's number one. So that means
2 to 3 hours in the air?
2 to 3 hours in the air. So there's preliminary data that's showing that that's a possibility there, that we may be seeing 2 to 3 hours in the air. And then those droplets can actually, of course, come down and land. on various surfaces. And we know that the coronaviruses in general can live, up to 9 days. I think that we're seeing with this virus, up to 5 or 6 days so far, but we know some coronaviruses can live up to 9 days. So we're talking, let's say a few hours to days for certain.
Wow, that makes it very difficult to protect against.
It is. And so that's why everybody is screaming the words of washing your hands, soap and water. And so, right now we have this major shortage, of course, of hand sanitizers and cleaners and disinfectants and things. But actually, if we just think about it and use soap and water, because everybody's got an abundance of soap and water, in the stores, they're still present, then we can actually still wipe surfaces, wash our hands frequently, prevent touching our faces, because if you do touch a surface, you don't want to inoculate your eyes, your nose, your mouth. You want to prevent that infection. And then if you're just washing your hands frequently, that will help, because you very well may come in contact.
What about spraying the air?
I keep hearing that question. And there are certain, cleaners and disinfectants that say you can just spray the air. I personally, I've never utilized them, in my scientific experiences. That's not something that, we use. We don't spray the air specifically. Now, there are certain instances, of course, where that is part of it. But in general public, really think about it. Even if it's in the air, it has to come down. So if you are cleaning your surfaces, wiping things down on a regular basis, in particular, what we call those high touch areas. So all the handles, the door handles, the cabinet pulls, your cell phone, that's a big deal. Washing your hands in between touching people. Stop touching people. I'm a hugger personally, but I've got to take a step back, right? We just have to do that. If you're cleaning everything regularly, then I think that we don't really have to worry as much about, trying to sanitize the air, let's say.
So let me take you back to viruses a minute, just because from a primary care understanding of viruses, I think of a virus as a protein casing with RNA inside. And then when we start thinking about how it's transmitted, the virus casing breaks open and the RNA invades our cells and creates an ooze, which is then fodder for secondary infections, bacterial infections.
Absolutely.
Can you start helping me think through the viral infection?
So for the viral infection itself, the virus, as you just mentioned, so it's got to have a receptor, and coronaviruses, utilize a couple of different receptors depending on the virus, right? So this particular one is using ACE2. ACE2 is found on a variety of cell types. It's found in abundance on our cardiac cells, as well as other areas of our body, which is, why we're seeing, people with cardiac pre-existing conditions being potentially at greater risk, as well as, people with lung disease and even the GI. It's found, some cells with ACE2 are going to be found in our esophagus, as well as in parts of our colon. So we have the cells throughout our body. The virus is going to bind, and then it's going to penetrate inside the cell. And as you described, it is going to, I call it unencapsulate, basically. So the capsid is going to disintegrate, and that's going to release the viral genome inside the cell. And so this is an RNA virus that's going to replicate in the cytoplasm. And so it's going to go through its full cycle. It's going to make more RNA. It's going to make its proteins that it needs inside the cell. So it's basically hijacked the cell. But the cell is still alive at that time. Of course, it has to stay alive for this to happen. And so when all those viral particles are made and reassembled completely, then it's going to leave the cell. And when that happens, now you've got a situation where you've got, potentially thousands of viral particles able to just go right along and infect any other neighboring cell that has ACE2 on its cell surface. And that's just going to continue. So is that getting at what you were asking?
Well, that raises two other areas of thinking, which is, one, does it attenuate after each person gets infected? Because we usually should say the first person and the first row of people you co-infect have the worst disease, and it gets softer and milder each subsequent case. Is that going to be the case with coronavirus?
Not specifically. If it was the case, I almost feel like we might have already seen that early on in China, perhaps before even recognizing it as this major new pathogen. What we're seeing isn't necessarily an attenuation just yet. Um, it appears as though people still have the same potential, excuse me, for the severe disease if they have those pre-existing conditions. Because at this point we're way past that front line of people, and we're still seeing the same type of illnesses, if that makes sense. Although, to be clear, the vast majority of people have still are, some are asymptomatic, some are mild, and some have, maybe an elevation of mild where they may experience more flu-like symptoms, but they're still perfectly capable of remaining home and, getting better, if that makes sense.
Sure.
But I don't know. I don't think that we're seeing that, what you've just described.
Interesting. And the other line of questioning is about developing a vaccine. Do you develop a vaccine to the protein, to the RNA, or do you actually take the blood of people who have recovered and look for antibodies?
Well, and so this is one area that I still have, to start digging some more deeply into, because there hasn't been a ton yet released on what exactly is going on here. Just that we know that there are a lot of people who are working on the vaccine. So, in answer to your question, what do we do when we've had similar types of outbreaks like this? Well, people who have recovered, of course, have antibodies. So those antibodies, when necessary, could be utilized to help others. And they could also be utilized, to see if we could make monoclonals perhaps that are similar, to determine exactly what those antibodies were for or against, I guess, which in terms of the virus, what were they targeting? And are they neutralizing? Could we recreate those? Now, is that actually being done yet in terms of, using antibodies to support other current patients? I can't speak on that specifically if that's happening, but that's one aspect. And then the other aspect is this. So for instance, we've got that spike protein, which is the protein that on the virus surface that actually is going to bind ACE2. Can we neutralize that in some way? So vaccines targeted at the spike protein are definitely being looked at. And there could be other aspects of this virus that we want to target depending on exactly, what they're causing. And so right now we're just trying to study all the different aspects, but I know the spike protein is a definite potential target for a vaccine.
So did you want to comment on the increase in cytokines and peptides and what's being called a cytokine storm?
Well, so I've seen a couple of reports on that, and you know, the last reports that I've seen, there's been this description of patients that are faring pretty negatively based upon the fact that they're having an extreme cytokine storm. I don't like the term storm, but essentially what that means is that their immune system itself is so over responding to this viral infection that they are secreting tons of cytokines that are in many cases pro-inflammatory, and it's creating a situation in their body where their immune response itself is actually causing such extreme detriment. And the why is this happening hasn't been able to be clarified just yet, but we're seeing this cluster coming out.
Although the data from China showed that steroids didn't help, and if it was an inflammatory response, they should have had more benefit.
It should have. It's very confusing, actually. And so, in terms of really what's going on, I'd like to see some more reports. I think everybody needs to see some more reports. But the last that I've seen a couple of days ago were remarking on this, and things being contra to what you might suspect should be working, actually, and it's just not. And it's not all of the patients. It's in some subsets of patients, but there's a lack of predictability in terms of who is going to actually have this response and why.
So in terms of treatment, we're seeing a couple of case reports of antimalarials and people trying other things. Um, if you had to think through it, do you think anything is out there that's effective right now, or is it basically supportive in time?
Overall, it's supportive. I've seen the reports, a few of them on the antimalarials. I've also seen using HIV protease inhibitors, which makes sense because this particular, at least in theory, it makes sense. This particular virus is also an RNA virus that also encodes for a protease. So that potential for a protease inhibitor to help stop this virus from cleaving the proteins that it makes down to the appropriate peptide length would be fabulous. So we've seen some reports on that. Now, are those patients fully recovering because of these particular drugs and individually, or is it the combination of supportive care plus the drugs? I don't know that that's been fully clarified, but it seems like some of those drugs are actually producing some success.
Interesting. So how do you see this resolving? Do you see the weather changing and when coronavirus season ends, or what do you think is going to happen in the near future?
That's such a great question, and everybody's asking. And if we think about what we know about some respiratory pathogens, then we would say that there's a potential for, as the warmer months come, for the numbers of infections to decline, because that's what we generally see with respiratory pathogens. However, what we've seen those 5 seasonal coronaviruses, a couple of them actually don't show a specific, propensity to decline in the summer. So there's a couple of them that, in temperate areas where it's really hot or even cooler, they're still circulating. So, even if that's the case, where this particular virus, SARS-CoV-2, was actually going to maybe have a reduction in circulation in the warmer months, there's still parts of our country, if we just look at the United States, that, have more temperate regions. And so is that going to work? I'm not sure. It's kind of, we're really in a wait and see, and is Mother Nature going to help us?
And I guess just a few last pieces to finish up. Why did it start in China, go across Europe, and come to the States later? Why were we protected for so long? And where do you see it going from here?
So why it started in China, in this case, in China, they often have these live seafood, as well as live animal markets, where, these animals, as well as, the seafood, and then of course lots of people are coming and they're commingling. Well, in these places, they also have the bats that we've seen. So we know SARS, for instance, we believe came in a similar type of transmission pattern there. So it started in China, of course, because that's where the conditions at this particular point for this virus were optimal. And then it spread through that population. But we're international travelers. I mean, this is such a global world. So there were people that were, of course, from parts of Europe that were in China at the time, or there were people from China that were potentially infected that traveled to parts of Europe. And so, I mean, they're closer than we are. So I actually think it just, in this case, the spread travels, the virus is going to travel through a proximity type of spread in that case, which is right, exactly. So when we look at the migration, I mean, we are actually further away. So kind of makes more sense for it to take longer. But, one thing is that has been said, if we look at, for instance, Seattle, which was the first major hot pocket of cases here in the United States, they believe that there were people probably walking around for approximately 6 weeks prior to the first cases being seen in Seattle. So, that tells us that, there's probably a lot more cases, and it probably came here earlier than we even know. But I think it's looking at migration patterns and just geographic distribution.
Any final thoughts or things people should be thinking about with coronavirus?
Well, in terms of final thoughts, I mean, the fact is that we are behind in terms of testing, and it is what it is. The NIH has Dr. Fauci has talked about it. All the leaders have talked about it. What we as Americans, I think, need to do is just take this seriously. In the sense of prevention, washing our hands frequently, cleaning surfaces frequently. In terms of mitigation, so many of us are doing this because our schools have shut down. Or at least partially shut down in some ways. Stores are shutting down. What we need to do, I think, as Americans, as human beings, is kind of just use common sense and take a step back. This is serious. We have an opportunity to really, really slow down that spread. As you talked about earlier, we've got the potential to really overwhelm the system, because our hospital systems and our health system, because of the time frame that a severe patient might need to utilize the services, and how many patients may need to utilize the services. And so if we just take a step back and maybe pay attention to our social distancing and the cues that the CDC is giving us and our health departments are giving us in terms of what to actually do. I think we can really, we have an opportunity to slow this spread down and to kind of flatten the curve as you described.
Dr. Cadet, thank you for your service in educating osteopathic medical students and spending the time today. I really appreciate it, and hopefully we'll get to talk again.
Thank you so much. My pleasure.
That was the basic science. Now we're going to talk about what we know about the clinical aspects of COVID-19. The clinical aspects are changing. We have information from China, we have information from Italy, but all crises are local, and the different population densities, the different cultures, and the different healthcare systems will determine what gets done. So we have Dr. Paige Gutheil from OUHCOM to talk to us about some of the clinical aspects she sees as a practicing DO and as faculty over at the Osteopathic Medical School at Ohio University. I appreciate having Dr. Paige Gutheil here today, an Associate Professor of Primary Care at the Ohio University Heritage College of Osteopathic Medicine in Dublin, Ohio, and she's the former Chief of Staff at Ohio Health Doctors Hospital. And we're going to talk a little bit about what's going on with coronavirus. So Dr. Gutheil, can you tell us what's going on?
Yeah, so as many of you have heard, the coronavirus, there's a new strain that has been identified originally from China that has now spread to over 100 locations that does not seem to be behaving quite as innocuously as the cold that we once knew, which is not new. We've known new strains of coronaviruses in the past that have had an increase in morbidity and mortality.
So how is this going to change life for our patients, and how's it going to change life for healthcare professionals?
Yeah, I think we have to be concerned about our entire community, and certainly healthcare professionals are on the front lines. And so COVID-19 seems to be spreading rather quickly and require a pretty large investment of healthcare efforts. Some studies show 15 to 20% of patients that contract COVID-19 will need some type of assistance in the hospital. And oftentimes that assistance is more intensive care, oxygen, ventilator treatment for long periods of time, so even weeks. And so you can imagine the exposure that our healthcare providers are getting. And of course, like we're seeing across the globe, it's on the mind of all of our patients and communities. And so everyone's affected in that way.
So if somebody called you up and said, I have a fever, I have a headache, and I'm coughing, what are you going to tell them to do?
Yeah, so I think a lot of what we'll talk about has to be prefaced with the fact that everything is constantly changing. You know, recommendations are constantly changing. And it's different, even recommendations are different where you live. So in certain communities where the cases in the community the numbers are higher, you'll handle things differently. And so that's why it's so important to take time to dive into the information and stay in touch with your local Department of Health, state departments of health, CDC, to know what's going on. But overall, at this point, today, Saturday, the 14th of March, what the conversation that we have is the typical history, right? When did this start? What exactly are your symptoms? Have you been exposed to someone that is known to have COVID-19? And a travel history as far as travel. And then depending on the area, if they meet criteria to be screened, then there's different recommendations depending on your local system where they will go to be screened. Some outpatient physicians are set up or will be set up to screen within office with the appropriate protection and precautions. But we know that fever, especially dry cough, malaise, those are the common symptoms. So based on what you said, those, that would flag that phone triage to be taken very seriously.
So in Maryland, we're sending them to the ER, and the ER is setting up diversion tents where they're going to triage people, and if they appear to be at high risk, they'll go to a portable or a tent or somewhere where they're away from other sick people. With the
Yep.
concern being if they come to a primary care physician's office, it could put more people at risk. And some of what we're talking about is if you're exposed, you have to be quarantined. If you have it, you have to be isolated. Can you tell us
Yep.
more about quarantining and isolation?
I'm one to always look at silver linings. I think that one of the silver linings of this conversation with COVID-19 is our culture, certainly among healthcare professionals, but in our community of working through it. And that's not the message to be given. As a society, we need to realize that if you're sick, you need to proactively remove yourself from exposure to other people to not spread illness. And so, that's true at any time, but especially true of this situation.
And one of the places where we've been hearing conflicting advice is what do you do with someone who has COVID-19? Do they need to test negative before they're allowed back into the community? How often do you test? And what is the course expected to be? How long are they sick?
There were original recommendations, especially with some of the positive, milder cases that we've seen in cruise ships and such, that we need 2 negative tests to return to the public. There's really recent data to show a little risk of reinfection, which is concerning overseas. So I think the take-home message is stay tuned, because that information is constantly evolving. But this is a prolonged illness. This isn't a cold for 5 to 7 days and then you're back at it. This can be weeks.
So right now we're in the prevention phase where we're starting to see the doubling every day, where we know it's coming and we know we're going to have to deal with it. But with us being still in the first few days of it, what do we do to prevent the spread of COVID-19?
Yeah. And again, that varies by location, right? Our colleagues out in Washington would probably not agree that we're in the prevention phase. They're in the thick of it. But in general, a lot of us over the nation are really ramping up to say, okay, we're taking this more and more seriously. And so, we start with the basics. We start with hand hygiene, washing our hands 20 seconds, rubbing hard, hand sanitizer, and basic precautions as far as if you are having symptoms, like we mentioned, isolating yourself, mask. One of the things that is hugely important in the conversation among ourselves and in community is social distancing. And so for a lot of our patients, they don't really know what that means or why they would have to do that. But the idea being that one of the best ways, and certainly in China, we saw the best way to get ahead of the curve, is to establish social distancing practices. So
Do soccer games for your kids or gatherings?
no, all of that has been canceled in my area. And you bring up a good point when it comes to the kiddos. This is an adult topic, and this is a time where it's up to the adults to lead in a calm and tactical manner. And our kids, it's not the time for total transparency, right? It's a time where, my kids know that they have an extended spring break, and we're going to do homeschooling, and we're going to spend time as family. And so, this is a time for creativity as a culture, I think, and certainly within the messaging that as healthcare professionals we're sending to patients. We have to be creative in what we tell our kids and connecting with friends and going virtual for our connections and helping even local businesses, in different ways. And it's a time for creativity and positivity as opposed to fear. Fear really doesn't get us anywhere. And, that fight or flight reflex that our nervous system has, it's not favorable for the immune system. So if not for any other reason to be calm, you can consider it stimulation of your parasympathetic nervous system.
Excellent. Any final thoughts for medical educators out there and for medical students?
I think my parting thought would just go back to, this is a time for leadership. This is the time to really have calm, tactical measures that are based in wisdom and a sense of unity among our profession. This is not the time to have a divided message. And so I would just urge everyone in every position, from pre-medical student who's watching like, hey, is this my future, to seasoned physician, to do their part,
Well,
Yep.
thank you for taking the time to talk with us, and I'm sure we'll be talking again.
Yeah, my pleasure.
Welcome. We have Dr. Bindu Mayi with us, who is a professor of microbiology at Nova Southeastern University. And she's here to help us understand testing for coronavirus and understanding the viral illnesses that we're seeing nowadays and need to learn more about. Welcome, Dr. Mayi.
Thank you for having me.
Thank you for talking with us, because we know we've seen coronavirus before. There are at least 5 types, 4 common ones and some uncommon ones. What's new about the coronavirus we're seeing now?
Like you mentioned, coronaviruses are a family of viruses. There are about 7 of them, 4 of which cause the common cold. And then we had SARS, which also caused atypical pneumonia, like the current one does. That was in 2002, 2003. Then we had MERS in 2012, also causing atypical pneumonia. And then we have the current one, which the disease it causes, we call it COVID-19. And that has been called SARS-CoV-2. And the reason for that is when we do genetic analysis and we try to put it in the phylogenetic tree to look at ancestry, it falls more closer to the SARS coronavirus. Okay, so it has close to 80% genetic similarity to the SARS coronavirus. Now, it is different from SARS virus because in the case of SARS, most of the infections were symptomatic, and it was symptomatic individuals that were contagious, which really allowed us to put in vigorous contact tracing, isolation, quarantining, etc., and keep the numbers down. So everything said and done, the human toll was about 774 deaths and just over 8,000 cases across 37 countries. We far exceeded that in the total number of cases as well as the total number of deaths so far with the new virus. So the biggest difference seems to be that even asymptomatic individuals are contagious with this coronavirus.
So one of the things doctors are saying is that over the past few months, we've seen a lot of cases that were flu negative that look like the flu. We've seen a lot of very sick patients with viral infections.
Mm-hmm.
Could this have been coronavirus, and how do we test for coronavirus?
So there is a kit that is being sent out by the CDC, which is an RT-PCR kit. So RT-PCR, because the genome of this virus is RNA, so essentially you're reverse transcribing RNA to DNA and then amplifying DNA. So at this time,
chain reaction that's going to just create a whole bunch of DNA from the RNA that's found in the oral secretions, nose secretions, blood, urine. Anywhere else you can test people for coronavirus? Any other fluids?
I think the recommended sampling, according to the CDC, have been upper respiratory and lower respiratory specimens, if possible, for lower respiratory. So that would be nasopharyngeal, oropharyngeal, sputum, if there is sputum. But the suggestion is not to induce sputum production. So that those are the recommended samples. And then we look for virus in those samples.
So we want to get an upper respiratory sample. We want to do a PCR. Why do we need a special kit? Can't we just do our RT-PCR on the fluid and see what we find, what the RNA looks like?
I think the FDA governs which labs are going to be allowed to do these testings. So as I understand, the current protocol is if the lab for instance, if the clinical microlab at your hospital is geared towards doing routine diagnostic testing for various infections and have the PCR machines, etc., then they can certainly make a request of the FDA to do the testing themselves, is what I understand.
And
So
even
it would fall
though
under,
we can do a PCR test looking for coronavirus, we always do a confirmatory. And was there an issue with that, with false negatives?
So the first test that got sent out, that seemed to be the issue, that the false negatives were also, so there are controls, right? So there are positive controls, negative controls, and then the test itself. So the issue, as I understand, with the first few kits that went out from the CDC, there was an issue with the false negatives.
Do you think that'll be an issue going forward?
I think they have fixed it.
So you were mentioning that there are certain commercial tests out there that make it easy and do it both at the same time will give you a simple answer.
Yes, so the FDA just approved Roche Diagnostics, Roche, which is a biotech company, to do the testing for the SARS-CoV-2 virus.
Can you test for cytokines or for antibodies?
I don't think at this time we have that, but that's a very good point, because a few months from now, for instance, when we do serological analysis of not just patients, but a huge chunk of the population, it'll probably give us a better picture of how many individuals have been exposed to the virus. And I say that because it is thought that the majority of infections are asymptomatic. However, asymptomatic individuals are still contagious and can spread the virus.
So why don't we have a panel that tells us which virus it is? Why do we have to test for each one individually?
Because this is a brand new virus still, I think in the future, we can certainly add this to a panel. If this becomes a seasonal thing, then we can certainly add it to a panel with other viruses and then look for it.
Do you think it will become a seasonal thing? Do you think there'll be an animal reservoir in the United States?
I don't think we need an animal reservoir anymore because we are seeing sustained human-to-human transmission. It certainly looks like it could become seasonal, but I think we can just wait and see what happens. At this time, that if I had to make a guess, that would be my guess.
Do you think the symptoms will change over the next year, or do you think it's going to be the fever and maybe some GI side effects, maybe cough and other vague symptoms along with it?
So we are seeing those other symptoms you mentioned. We are seeing them already, just not as commonly or as frequently as fever and cough and shortness of breath. I just don't know.
Do the symptoms of a viral illness become more consistent for a disease?
How do you mean that?
So we know the first time that somebody gets a new virus, it's usually more virulent and you get a worse case. And that as time goes on and as spread goes further away from the initial case, the symptoms lighten a little bit. We see more similar as time goes on, or is that?
I don't, all good questions, but I think over time we will know the answer. And I say that because we don't know if we think that maybe people who do get infected become immune and are not subject to reinfections, but we just don't know. So it's just time will tell us.
Good advice. Any other thoughts on testing for coronavirus and things that people should know?
At this time, no, unfortunately. But I really like that Roche, which is a reputable company, has a test that has been FDA approved under the emergency use authorization. And so the test is available here in the United States. Excellent. Which I think will dramatically increase access to many labs across the country.
I think you're right. Having an objective standard to use is very effective and very important. So a lot going on, a lot of changes, but I appreciate your insight into testing for coronavirus, and I appreciate you taking the time to answer our questions.
Certainly. Thank you for having me. Have a wonderful day.
Thank you. Hello there. Welcome. We have Daniel Hurst, the Director of Medical Professionalism, Ethics, and Humanity at Rowan University School of Osteopathic Medicine. And he's going to help us think through some of the professionalism issues and some of the ethical issues that are going to come up because of the COVID-19 issue that we're experiencing right now. So, Dr. Hurst, from a professionalism and ethics viewpoint, what is the role of a medical student or an osteopathic medical school during a pandemic or a disaster?
Yeah, great question. First, just thanks for having me. I think a lot depends on the particularities of the pandemic or the disaster that we're facing, right? So what we're seeing on the ground right now with COVID-19 is a drastic shortage of PPE, personal protective equipment, in many places. I think that this does have the potential to impact what role the medical student is going to play during a pandemic or disaster event. So when PPE is in short supply, then clinics, hospitals, all these clinical settings, they're faced with the tough decision of how best to use those limited resources, how to supply them, things like that. And medical schools are also having to make tough calls about the role of their students in these situations. And one such decision that many may choose to make is that PPE should be reserved for those persons providing critical clinical care and not for purposes that are primarily educational, so not for students. If items were not in short supply, if there was just an abundance of PPE, then the conversation would probably be drastically different than that. But the situation on the ground that I'm seeing reported in the media, at least, is that what we're seeing may preclude certain learning opportunities for students.
So you're saying that the school has an obligation to have a safe environment for students to learn, and if
That's
the
right.
environment isn't safe, that they are no longer able to learn in the same way?
That's right. And those students are not actively perhaps contributing to the patient care, but they're mainly observing, watching. These are educational opportunities. And so we're taking those materials, those supplies away from actual practitioners who need them.
Well, we know in the past, like during the 1980 flu pandemic, that medical students were recruited to act as stand-in for physicians and nurses and to supplement a workforce that was weakened by the infection. What are your thoughts about recruiting students to act in those positions?
Yeah, that's right. So hopefully we won't come to that, right? But it's definitely an item that we need to think through. What I think is perhaps more realistic and where students could contribute to the clinical mission in an important way during the COVID-19 pandemic is through perhaps non-traditional clinical services, such as telemedicine. So many health systems have begun to ramp up their telemedicine capabilities for the COVID-19 pandemic. We all know that one of the most worrisome aspects of COVID-19 is the surge that it could create for a healthcare system, right? We've all seen the graphs, the charts about flattening the curve. And so this is something that China experienced, and they had to build their makeshift hospitals to handle it. It's something that Italy is currently experiencing, and they've not been dealing with greatly. And there was an article that I read recently from NEJM that came out a few days ago, and it was by Judd Hollander and Brendan Carr, and they talk about one of the central strategies for controlling the healthcare surge, and it's termed forward triage, and the triaging, the sorting of patients before they arrive to the ED setting. Telemedicine is essentially a 21st century approach to forward triage that allows patients to be efficiently screened. It's conducive to self-quarantine and social distancing, and it really protects the patient, the clinician, and the community from further exposure. And so this could be a very important way for our medical student workforce to be involved in the clinical mission during these times.
And that sounds like in an ideal situation, you know what the risks are and you evaluate them beforehand. If you're in a situation like you see someone pass out and you're in the ER, you don't know if they may or may not have COVID and they may benefit from mouth-to-mouth resuscitation.
Right.
What's the student's response in those situations?
Yeah, I think the student's response is to do the best that they can to protect themselves during that event. But they do have some responsibility to that person as well as a healthcare worker. Yes, granted, they are in a learning role, a learning capacity, but just as being part of the medical workforce, they have some responsibility as well. So trying to do the best to protect themselves during that event.
And you talk a little bit about expanding the role to doing telemedicine and non-traditional roles in medicine. We just saw thousands of people, or whole communities, rush supermarkets for toilet paper and water.
Right.
What happens when whole communities rush a hospital for oxygen and ventilators?
Right. Yeah, we've seen in the past few days a lot of ethics papers come out about quarantine, well, not about quarantine, but about rationing, different supplies, things like that, how best to do it. You know, do we give the ventilator to the pediatric patient or to the older patient, things like that. And so these are issues that we need to be thinking through right now before we get to that surge, so that if and when we do get there, then we have the policies and the practices in place and know how to best handle it.
So what questions should a student be addressing now so they're ready to answer it in an emergency?
I think similar to the things that we've talked about. So what kind of risk exposure are they willing to put themselves to? So the person who does fall out in the middle of the ED and there's no way to put on a protective mask or something for mouth-to-mouth resuscitation. What are they going to do? What are they comfortable with? What exposure? You know, things like reading some literature on the rationing of ventilators and items like that, so that they can have more of a moral framework to approach these issues from.
Are there any things you would suggest reading or any articles that would be helpful for them to review beforehand?
Yeah, there's a very accessible article by Ezekiel Emanuel, previously at the NIH. I think he's at Penn now. And a guy named Govind Prasad, who's at, I believe, the University of Colorado, but they had a New York Times opinion piece just a few days ago that would be helpful reading.
Well, thank you for taking a few minutes to talking with us. Any final thoughts or recommendations for students?
No, I think that just about covers it.
Well, thank you. I look forward to talking with you further. Appreciate it.
Thank you.
COVID-19 is a rapidly changing, rapidly evolving healthcare issue. We're just giving you some of the basics here and introducing the issue. AUHCOM has a page up on our website, a coronavirus resource page that will be updated regularly, and we'll share key articles and critical issues that you need to be aware of. Thank you for joining us. We're happy to answer questions and happy to work with you. Thanks. Bye-bye.